Thank you for the opportunity to present today. I have no disclosures. Weight regain after Roux-en-Y gastric bypass occurs in nearly 20% of patients. Distal bypass revision can help to increase the malabsorptive component of a standard Roux-en-Y gastric bypass by lengthening the BP limb and shortening the alimentary limb to also result in hormonal changes that promote increased weight loss. This is known as the foregut and hindgut hypothesis. While several pharmacologic, endoscopic, and surgical interventions exist for weight regain post-bypass, the ideal or optimal treatment algorithm has not yet been determined. To this end, we wanted to report our initial experience using distal bypass revision for weight regain in bypass patients and provide a comparison with patients and their weight loss outcomes after primary bypass. So this study was performed in a single academic institution and was a retrospective review from patients undergoing surgery from 2018 to 2020. Variables of interest included demographics, comorbidities, and surgical technique. The control group that we created consisted of primary Roux-en-Y gastric bypass patients that had surgery at approximately the same time as our revisional patients, and similar weights and postoperative weight regain. Outcomes of interest were complications, vitamin deficiencies, comorbidity resolution, and overall weight loss data. Within our study group, we also looked at the postoperative weight loss following primary bypass and distal bypass revision operations in the study group. So for our surgical technique, this was relatively standardized between 4 surgeons, completing 16 cases. We did a total intestinal limb length measurement as our starting point in each operation to ensure that there was adequate length for distalization. The BP limb and alimentary limb are identified and divided at the jejunum with the linear staple. The common channel is then measured from the terminal ileum and you're going retrograde about 150 centimeters to create our new jejunostomy, which is constructed using a 60 millimeter linear stapler, and the common enterotomy is closed in a single running fashion. The mesenteric defect is then closed with non-absorbable suture to prevent internal hernia formation. The median length of the constructed root limb in this study, and common channel as well, was 150 centimeters each, giving us a total alimentary limb length of approximately 300 centimeters. All of these procedures were performed laparoscopically or robotically, a slightly higher tendency towards the robot. So in terms of postoperative management, we followed our standard ERAS protocol that we follow with all of our primary bariatric patients. They were also continued on APPI postoperatively and extended DVT prophylaxis if indicated with risk calculation scores. Patients were followed routinely, and our nutritional lab protocol is listed here. Labs are checked more frequently for our revisional distal bypass patients than they are for our primary bypasses. Most notably, their labs are checked every 3 months in the first year versus every 6. Additionally, prealbumin, looking for protein calorie malnutrition, and additional vitamin deficiencies and nutrient deficiencies are checked only in the presence of symptoms. So in terms of our results, the patient groups were relatively similar. There were no statistically significant differences in the groups outside of age, which would be expected because the revisional operations were occurring later after primary bypass for our study patients. And then there was a slightly higher rate of diabetes in the control group who are pre-bypass patients, so this is also expected. So for mean postoperative weight loss outcomes, there was no statistically significant difference between the BMI or weights postoperatively between our distal bypass revision group and our control groups. What is of interest, however, is the percent excess weight loss, which was higher in the control group throughout our study period. Again, this is expected given that our distal bypass patients are likely have a lower BMI starting. Of note, though, is this graph here depicts the difference between the overall excess weight loss was closing after towards the end of our study period, which was 2 years. It did not reach the level of statistical significance, but I think the trend is important to note. So for mean excess weight loss at 1 year post-operatively, the primary group, so undergoing root-and-wide gastric bypass at 67% versus a revision, which was at 50%. And then the number of patients that were able to get greater than 50% excess weight loss, so what we would deem a successful weight loss post-operatively, was 75% in the primary and 33% in the revision. Again, given our small sample size, we did not achieve statistical significance here, but the trends are in line with what we would expect. We did use logistic regression to adjust for age, pre-op BMI, history of comorbidities, and found that there was a statistically significant, a higher odds of achieving greater than 50% weight loss, again, in the control group versus the bypass. So in terms of overall complication rates, they were higher in the study than some of the previous reviews that have been published. So 30-day complication rate was 25%. We had a 30% readmission, 31% readmission, and 2 patients required reintervention, so for 12.5%. One patient had a bleeding ulcer that required endoscopic intervention, and the second patient required return to the operating room for exploratory laparotomy with small bowel resection due to obstruction and subsequent ischemia from adhesive disease. Overall, there was no mortalities or a need for reoperation for limb lengthening. Vitamin deficiencies were also low. We did, out of our 16 patients, we only had complete data for 8 of these patients, which is important to note. I used several patients elect to have their labs drawn in outside facilities, which are not commonly uploaded into our system, so we couldn't have accurate numbers in order to evaluate all of our patients of follow-up. And the incidence of comorbidity resolution was high for all the patients in the distal bypass group, particularly hypertension, GERD, and diabetes, which is also consistent with the existing literature. So limitations of the study, we had a small sample size. This could also be due to our patient selection criteria, which is relatively strict. There's a retrospective review, so there's information bias and recall bias there. And we had a 2-year study period, so we're lacking more long-term data. So ultimately, our distal bypass patients had excellent weight loss results. 33% were able to achieve a greater than 50% excess weight loss at 1 year. We think that the study outcomes can help when counseling patients regarding distal bypass revision as a treatment option for weight regain post-bypass. But we still need to determine whether this is more beneficial compared to other treatment options, including endoscopic interventions and pharmacologic agents.